Hello, everyone, and welcome to this second session of the Liver Health Project Echo Group. This was created to bring treatment and prevention best practices for NAFLD, now known as metabolic dysfunction associated steatotic liver disease. This session is being recorded just so everyone knows. Please mute yourself unless you're asking a question or presenting. We'd love to learn a little bit about everybody that joined us today, even if you shared last time. So please introduce yourself if you don't mind. We'd love to get your name, location, any organization affiliation, any other information you'd like to share. So please type that in when you get a chance. We'd love to hear from all of you. And I'm going to go ahead and jump right in and introduce our first two speakers. So this is Dr. Norah Terrault. Dr. Terrault is a transplant hepatologist, Neil Dukewich, Professor of Medicine and Chief of Gastrointestinal and Liver Diseases Division, Keck School of Medicine at the University of Southern California in Los Angeles, California. She has focused her clinical and research activities on viral hepatitis and fatty liver disease, with specific focus on patients with cirrhosis and liver transplant recipients. In addition to multiple clinical trials related to preventing and treating chronic hepatitis, viral hepatitis, and fatty liver, Dr. Terrault has been a PI on multiple NIH-funded studies, including the current NIH-supported HBV Clinical Research Network, Non-Alcoholic CF Hepatitis Clinical Research Network, and Liver Cirrhosis Network. She has authored over 400 peer-reviewed manuscripts, editorials, invited reviews, as well as the U.S. national guidelines for treatment of chronic hepatitis B, C, and reproductive health. Dr. Terrault served as the 2023 MASLD. We also have with us today Dr. Matthew Dukewich. Dr. Dukewich is a gastroenterology and hepatology fellow at the University of Southern California, where he will also complete his transplant hepatology fellowship. He's a fellow in clinical hepatology research, where his work focuses on the influence of cardiometabolic comorbidities on clinical phenotypes of steatotic liver disease. He also has a clinical and research interest in alcohol-associated hepatitis, and published work on these roles and benefits of early liver transplantation. So thank you both for joining us. I'm going to stop sharing my screen and I'll take over.
So first of all, let me thank you for the invitation. Matt and I are going to do a tag team approach to the session today. What we're going to plan is that we're going to present some information, and then I'll do that, and then Matt will follow with some cases to illustrate the points. And then we'll kind of move through a series of specific information that way. And we would really love it if you participate. So when Matt presents the cases, he will be posing some questions. We would love it if you would chime in. You can use the chat. I'll monitor the chat, or feel free to unmute yourself and also answer. But hope to have you engage with us in the session today. Next slide, Matt. So the objectives we have, we were given the topic of screening for MASLD. And we took a why, who, how, and when approach to this topic. The why being, why do we need to screen for MASLD? The who is defining who you should screen, how to do it, and in doing so, focus on first-line tests, and then sort of second-line or risk stratification, and then finally, when to repeat. So we'll cover each of these topics, and as I said, each with some cases. Next slide. So first of all, the component of why do we need to screen? These are data from adults in the United States. This is taken from the general population called NHANES, and they look between the years of 2017 to 2020. And using information about individuals based on a FibroScan, which is a vibration-controlled transient elastography, which is a way to assess for fat in the liver using an ultrasound technique. And with the presence of metabolic risk factors, they identified that basically 1 in 3 American adults have MASLD. So the first reason to be screening is that this is an incredibly common condition. Next. But the other thing about MASLD is that it can be easily missed. And the reason it can be easily missed is that it's typically without symptoms until very advanced in terms of the disease, typically when people have cirrhosis and its complications. So in the earlier stages, it's very difficult to make the diagnosis unless you're thinking about it or looking for it. And even when patients do have symptoms, they're very often nonspecific. The second is that the physical exam is also typically normal. While you may see hepatomegaly as a finding on your exam, or when again they have cirrhosis, see more advanced findings such as splenomegaly and cutaneous stigmata of cirrhosis, again, earlier on in the disease, the exam will be normal. And then finally, liver tests. So often we think about, when you're going to make a diagnosis of a liver disease, the liver tests will be elevated, but very often in MASLD, these can be normal or can be minimally elevated. And I'm going to just take a second to remind you all that a laboratory normal is not equivalent to a normal from a standpoint of a hepatologist. That if you look at a population, a true normal ALT level in a male is 33 or less, even though your lab normal may say it's as high as 50 or 60. So when you look at an ALT level in a male, anything over 33 should raise concerns that this is abnormal. And for females, it's anything over the level of 25. So those are the true normals. So even though your laboratory normal might be different, that's what should sort of in your mind raise concerns about a possible underlying liver disease. And indeed, individuals who have MASLD, when they do have liver test elevations, typically it's the AST and ALT that will be elevated. Next. And of course, the whole reason we're having this session today is to really highlight that it's underdiagnosed because of the fact it's common but doesn't present easily, and that there's a high need for us to think about diagnosing early. What we want to do is find individuals at the stage on the left when they have steatosis or when they have steatohepatitis, where the fat may be treating some inflammation or fibrosis, but clearly what we want to do is diagnose them before they get to cirrhosis. And that's because if we identify them earlier, we have an opportunity to intervene and actually prevent that progression to cirrhosis. So the whole impetus behind screening is to find them when they're in the stages of steatosis or steatohepatitis. Next slide, Matt. And then now moving on to the why, that was the why we screen, now the who. Currently, the recommendations are as follows, that you shouldn't screen everybody. You might think, well, if it's 1 in 3, maybe I should just screen everybody in my clinic, but that's not the current recommendation. The current recommendation is, first of all, to think about people who have cardiometabolic risk factors. And those risk factors are shown on the right. They include an elevated BMI, and note that for individuals of Asian race, that BMI cutoff is lower, or increased waist circumference, right? That's one. Individuals with elevated insulin resistance or diabetes, those with hypertension, those with dyslipidemia, right? So if a person has abdominal obesity and one other cardiometabolic risk factor, so they have hypertension or hypertriglyceridemia, for example, that would be an indication to screen. So obesity plus another metabolic risk factor, screen those individuals. Secondly, anyone who has diabetes is recommended to be screened because that is probably one of the strongest risk factors aside from obesity that is associated with steatosis. So that's another reason to screen. And then, of course, people often get imaging done for all kinds of reasons. They present to the ED with abdominal pain, they get a scan. And then steatosis is picked up on that imaging. So if you find someone who's got that kind of presentation, then that's an individual, then you should formally screen for MASLD. Anyone who has elevated liver enzymes, and remember that I just shared with you that elevated liver enzymes is greater than 33 for a male, greater than 25 for a female. And then finally, anybody who's got a first-degree relative who's developed cirrhosis related to metabolic-associated steatohepatitis or MASH. So those are the current recommendations on who should be screened. Next slide. So I just wanted to review that it's so common that people pick up on imaging and steatosis. I thought I'd spend just a second to sort of comment on how the radiologist arrives at that diagnosis. Shown on the left are steatosis, and you can see up in the left-hand side of the slide, the liver is sitting there, and right next to it is the kidney. And then up at the very top is the diaphragm, just to orientate you to that view on the ultrasound. So what the radiologist is looking at is comparing the echogenicity of the liver versus the diaphragm and to some extent the kidney. So in a normal ultrasound where there's less than 5% of the hepatocytes that have fat, I'm showing you a normal figure in the far left upper corner. For somebody who has grade 1 steatosis, which is by definition up to 33% of the hepatocytes have fat in them, then that's when the echogenicity of the renal cortex, the echogenicity in the liver is greater than that of the renal cortex. So that's shown in the upper right. And then when you get to grade 2, which is where up to 66% of the hepatocytes have fat in them, then you'll see that what happens is there's some obscuring of the vessels within the liver. And then finally, grade 3, which is where when more than 66% of the hepatocytes have fat in them, that's when you see that you've kind of lost the definition of the vasculature within the liver, and the diaphragm becomes indistinct as well. So that's how the radiologists make the call. So you'll often see that they comment on increased echogenicity, and increasingly what we see in reports is they'll comment on grade 2 or grade 3, and what they're referring to are these findings. And similarly, they have additional criteria that they use on CT or MRI imaging, but in most settings, ultrasound is the test that's often identifying steatosis. Next. Now, it's worth mentioning that while this talk is on MASLD, and the emphasis on identifying individuals who have MASLD, when you do identify somebody who has hepatic steatosis, it's important to remember that more than MASLD can cause liver fat. And the big ones to consider are alcohol. That can also result in steatosis and steatohepatitis. Certain types of hepatitis C, genotype 3 in particular. So if the individual has hepatitis C, that can cause fat in the liver. And then there's a number of medications, and I've listed the key ones, the most kind of frequent ones that we see. And just to keep in mind that if you have a patient who's taking these medications, that could be the cause for their steatosis. Doesn't discount the fact that they have steatosis, but it influences, of course, how we approach treatment. For these individuals, we would treat them quite differently than a patient who has MASLD. And then shown on the right are some of the rare causes. And I'm not suggesting that you would evaluate for these necessarily in any patient or very few. It's a very select group that move. These are kind of the testing that I might do in my clinic for individuals who've been seen and where there's a concern for these other conditions. But really the common ones are the ones I want you to think about: alcohol, hepatitis C, and medications. Next. So now I'm going to turn it over to Matt, and Matt's going to try to reinforce some of these initial concepts with some cases.
And so starting off with kind of thinking through this framework, we're going to talk about who to screen. So this is a patient case, maybe someone that commonly seen, a 48-year-old female presenting to established care with no known medical history, but does admit to not having any medical exams in a few years. She was recently in the emergency room for non-specific abdominal pain, where an ultrasound was reported as hepatic steatosis. Her BMI is 22, no alcohol use, and no family history of liver disease. Should this patient be screened for MASLD? Either shout out answers or throw them in the chat.
We're going to try to get you to do audience participation. It can be kind of tricky, I know. But if you want to just give a thumbs up or thumbs down for screen, yes or no. So yes. Okay, thanks.
Yeah,
Caitlin.
there we go. So yes, the key point in this case was that the ultrasound showed hepatic steatosis. So even though even kind of another benign medical history, the steatosis alone should push for screening. Okay, a second case This is a 63-year-old female presenting for routine follow-up. She was born in Japan, but came to the United States about 35 years ago. She's managed for type 2 diabetes with empagliflozin and metformin, has a BMI of 25, no alcohol use or family history of liver disease, and routine labs are obtained. AST is 21, ALT of 20, her A1C is 6.1, and has normal lipids. Should this patient be screened for MASLD? Yes, yes. See some yeses in the chat. And exactly. So this is this patient would highlight the type 2 diabetes history. So that is one criteria that requires screening for MASLD or prompt screening for MASLD. Also just highlight the her being born in Japan with Asian ethnicity. Remember that the cutoffs for Asian ethnicity, the BMI is 23 for the overweight category, according to the World Health Organization. So while this BMI of 25, it's just important to note that there are some adjustments for different ethnicities. And a third case, so this is a 56-year-old male patient presenting for routine follow-up, hypertension history, pre-diabetes, patient's on lisinopril for the hypertension, has a BMI of 27. He reports drinking 1 to 2 beers, 4 to 5 days per week, no family history of liver disease, and has routine labs that show an ALT and AST of 51 and 52. Should we be screening this? And I see some yeses. So yeah, so this is a patient that has kind of a few factors that would prompt us to screen. So kind of 2 cardiometabolic factors, the hypertension and the pre-diabetes. Also with an elevated BMI greater than 25, and then just highlighting that the ALT and AST are elevated above the upper normal limit here, and so would probably prompt screening on their own. So just the key takeaways from these patient cases and focusing on who to screen for MASLD. The important thing is that if it's someone who has a presence of abdominal obesity and cardiometabolic risk factors, those cardiometabolic risk factors being glucose intolerance or diabetes, we have hypertension, and we have hyperlipidemia as defined as either low HDL or elevated triglycerides, patients with a history of diabetes, those who have steatosis that is seen on imaging, and especially in these patients, if they have not already been screened for cardiometabolic risk factors, this may be a reason to screen for those cardiometabolic risk factors. We should screen those with an elevated ALT or AST, and this is also a good chance to screen for some common causes of elevated liver enzymes, such as alcohol, viral hepatitis, or medication use. And then in those who have a history of MASH or MASLD-related cirrhosis in a first-degree family member, they warrant screening as well.
Right. All right. So now we've decided who to screen. Now the next step is how. And for this, I just wanted to start by saying that the primary goal of our initial screening is to define really 2 buckets of patients, 2 groups of patients. And while they all are MASLD, they fit under the umbrella of MASLD. We know that of individuals who have MASLD, about 80% of them will have steatosis alone and will not have any significant inflammation or fibrosis related to that steatosis. But there's about 20 to 25% who have that inflammatory fibrotic phenotype. They're the group in which the fat has triggered an injury in the liver that then moves on to developing first inflammation, and then ultimately that inflammation injury produces fibrosis. And it's important to distinguish these 2 groups because our approach in terms of treatment is different. Clearly, the group that has MASH is a group that's at much higher risk. It is at risk for progressing to cirrhosis. And so that's the group we really want to be aggressive about targeting their disease and trying to prevent progression. Next. And you'll hear very often when people are talking about the stage of disease, they're referring to the amount of fibrosis that's present. And I'm showing you here liver biopsies because initially that was how we made this diagnosis. And so our definitions of the fibrosis are based on biopsies. But these days we don't do biopsies very often anymore, but we have done a lot of testing to show how non-invasive tests correlate with biopsy findings. And our goal with the non-invasive tests is to identify those that have F2 or higher fibrosis. And what's F2? Well, shown on the figure is going from left to right, the stages of fibrosis. So on the left is stage 0. This is a patient who's got fat in the liver. You can see the white kind of globules there. Has steatosis, but doesn't have any fibrosis present. The fibrosis shown by the blue. And I'm going to have Matt kind of highlight some of this. Stage 1 is where you start to get a little bit of fibrosis around the portal tracts. So that's shown in the stage 1. When you get to stage 2, the fibrosis now in the portal tract is starting to have little septae that come out from the portal region. And they start to move towards other portal regions. And stage 3 is when you start to have now clear bridging of fibrosis between the portal tracts. And then finally, stage 4 is when you have cirrhosis. You can see these broad bands of collagen, that's the blue, and you can start to see they now sort of separate off and form nodules. What we're trying to do when we do our non-invasive testing is to find, we're using tests to correlate with F2 or higher. So that's been shown in natural history studies that that group is the group that over a period of 5 to 10 years are at highest risk for developing the complications of MASLD, and that's the target group for specific therapies. Whereas those that have stage 0 or stage 1, we're more focused there on, okay, let's focus on how do we reverse the steatosis. Most of the medications we use for treating MASLD are not for that group of patients, but only those that are F2 or higher. Next slide, please. Okay, so that's just to kind of lay the ground for what's F2 and higher. I'm not going to be, we're really referring to biopsies beyond that. So what is the initial screening test for suspected MASLD? Well, it's the FIB-4 test. A FIB-4 test is recommended because it's simple. It's based on lab tests that you can get anywhere, and is a very good first level test, non-invasive test, to help us identify, again, the major differentiating in terms of low risk versus high risk for fibrosis. So FIB-4 is age, AST over platelets times ALT, and over ALT. And there's a calculator. You know, you can't do this in your head, but there's plenty of calculators. I've given you just one website. I have on my phone and on my computer this one that's identified. And you're going to calculate the FIB-4 score. If it's less than 1.3, this is somebody who has very low risk for fibrosis. We consider this to be somebody that's in that F0 to F1 category. Whereas if they have greater than 2.67, then they're in the at-risk group of F2 or higher. This has been done where they correlated the FIB-4 with actual biopsies to come up with these numbers. Now, one thing that's a bit of a caveat with respect to the FIB-4, you can see that age is part of the equation. And when they developed this score, most of the individuals were between the ages of 35 and 65. And it turns out that if you're less than 35 or over 65, then the correlation between FIB-4 and the fibrosis level is a little less perfect. So it's recommended, for example, if you have a patient who's over 65, that the threshold to define low risk of fibrosis is not 1.3, but less than 2. Okay, so just keep that in mind. And if you have somebody who's less than 35, generally, I'm always looking to see if there's another way that I can evaluate them for their fibrosis stage, again, because the FIB-4 being somewhat less accurate. Next slide. Now, the other test that you can order, although it's a send-out test, it's a specialized test, but you're going to hear about it, is something called ELF, E-L-F. This blood test combines several different molecules that have been involved in both making fibrosis and actually breaking down fibrosis into a particular score. When you submit a blood sample for ELF, you're going to get back a report like the one on the right. This is from one of my patients. It gives you the ELF score, and then it interprets that ELF score for you. And again, studies have taken these scores, which are blood tests, and correlated them with the biopsies again. And what we know is if you have somebody whose ELF score is under 7.7, is under 7.7, then that's a patient who's at low risk. Similarly, if their level is 7.7 or higher, then that's an individual who we'd put in that higher risk group where we would want to do more testing. So you can see that this particular patient, their ELF score came back at 7.82. That is not less than 7.7. So this individual is not in the low risk group. That would be in this group that's F2 or higher. So FIB4 and ELF are both blood tests that you can use to do your initial evaluation of patients who have suspected MASLD. Now, FIB4 is simple because it's based on a CBC and a CMP, so it's very cheap. ELF is a send-out test and it's a bit more expensive, but it is available. Quest, LabCorp now offer this test, so it is one available to you. Next. So just to highlight FIB4, because that really should be your go-to test for most of your patients, especially those between the ages of 35 to 65. And this is just to show, again, when you use as the initial screening tool, then what they did here is they looked at those that got FIB4 results and then correlated these with liver stiffness measurements. And I'm going to be talking about liver stiffness as another tool. Liver stiffness is measured by the FibroScan or elastography. It's an ultrasound-based test. And I just want you to focus on the top bar. Again, that low-risk group where their FIB4 is less than 1.3. You can see that it's quite accurate at identifying that low-risk group. So when they use the liver stiffness as kind of the gold standard here, 90% of patients who had a FIB4 less than 1.3 were indeed also had a liver stiffness measurement that indicated that they had a low risk for fibrosis. So it's very good at identifying that low risk group. It only misclassified 10% of the patients. In contrast, let's go to the far end, which is the group that has that FIB4 greater than 2.67. Remember I said that that's the group where we'd be concerned that they have a higher risk of fibrosis, F2 or higher. Well, here you can see that the actual true positive rate in terms of who has advanced fibrosis was only 21%. And there's a high rate of misclassification. We understand this. The FIB4's purpose is really to primarily identify who does not have fibrosis. So it's identifying that low risk group, whereas the higher or intermediate risk groups need more testing to define their actual risk, because the FIB4 doesn't do a good enough job of ascertaining whether they are truly at high risk or not. And that's what this study shows, is that you need second line testing if you have someone whose FIB4 is 1.3 or higher. Next. So just to sort of put it all together into that initial algorithm for testing, you have a suspected diagnosis of MASLD, based on they have risk factors, the imaging, the family history. So you're going to perform first of all, the first thing you're going to do is kind of make sure they don't have another obvious explanation for their liver test abnormalities or for the NAFLD, like a medication. And then you're going to do your FIB4. If your FIB4 is less than 1.3, you are done. No further testing is needed, but it is recommended that you do repeat testing of these individuals if they remain with risk of MASLD every 1 to 3 years. And I'll show you the intervals on the next slide. But note here that if they are individuals whose FIB4 is 1.3 or higher, or their ELF score is 7.7 or higher, those individuals are going to need more testing to establish if they really have at-risk MASLD. Next slide. So just in regards to the serial testing in people who are in that low risk group, so you test them, their FIB4 is less than 1.3. When do you repeat it? Well, what's been recommended is that if they have type 2 diabetes or if they have 2 or more cardiometabolic risk factors, they should get FIB4s done every 1 to 2 years. I recommend to my primary care physician, they should do it annually as part of an annual checkup or physical. If they don't have diabetes and they don't have at least 2 cardiometabolic risk factors, then it's recommended you could do a FIB-4 every 2 to 3 years. So they're a much lower risk group. And then I want to highlight that if you have somebody who's in this sort of low risk group, but now on testing, you see that their AST and ALT have become elevated, then at that point, it's recommended that you would then do repeat FIB-4 because it represents a change in the status of their liver disease. So you'd want to do, again, renewed risk stratification. So repeat the FIB-4 and then make decisions about whether you need to do additional staging data. Okay, I'll take it. Matt will take it from here.
Okay. Jumping back into some patient cases, help consolidate these initial screening approaches. So this is our the 56-year-old male patient here for routine follow-up, hypertension, prediabetes, a BMI of 34. His ultrasound showed hepatic steatosis, has an ALT of 51, AST of 52, and platelet count of 200. Which initial testing is indicated? And then based on that, do we need anything additional? And so I see FIB-4, perfect. So yes, so we calculate a FIB-4 using MD-Calc for this patient. We get a score of 2.04. So based on the cutoffs, does a 2.04 warrant additional non-invasive testing, or what would be the next steps? So some additional testing is recommended. Yes, perfect. And we'll kind of work on highlighting that in some of the next slides, but important that this patient does require some second step testing. Yes. So a second case here. So this is a 66-year-old female, BMI is 31, prediabetes. She did have an ultrasound that had hepatic steatosis. AST and ALT are 21 and 20, so within normal limits. It has a platelet count of 280. So which initial testing are we doing for this patient? And then we would think about, based on that, if there's any additional non-invasive testing needed. Good. So we'll start with the FIB-4 again. We plug this in on MD-Calc. We get a 1.11. So kind of jumping ahead here, this score of 1.1 puts us in the low risk category. I do want to highlight that this patient over 65, so we can use that cutoff of less than 2 rather than less than 1.67 for the low risk category. We go back and think about her risk factors. She does not have diabetes. She only has 1 cardiometabolic risk factor. So this is one that at this time does not require additional non-invasive testing. And then we can repeat FIB-4 screening annually to every 2 years, but annually is reasonable given age. So then the same patient comes back, sees you in 9 months for follow-up, has a CMP performed and shows an ALT of 60 and an AST of 54. Does this change the screening interval? So I guess it doesn't, yeah, these are good points. It doesn't change the interval, but given the new change in the liver tests, we would probably recommend repeating a FIB-4 at this time. And yes, also consider other causes of a new change in this ALT and AST. And then, whether it's alcohol, new medications, or, in certain participants or certain patients, whether other cardiometabolic risk factors have changed or developed in the interim. So yeah, so the important thing here is that depending on the results of this repeat FIB4, the screening interval likely doesn't change if we're already doing it annually, but to highlight when there's a change in liver tests in the ALT and AST that a repeat FIB4 is reasonable to perform at that time, even if it's not within the standard screening interval. A third case here, so this is a 59-year-old female patient, diabetes, hypertension, hyperlipidemia, BMI is 34, AST is 58, ALT is 40, it has a platelet count of 180. So which initial testing is indicated, and then when we order that initial testing and interpret it, we want to think about whether additional non-invasive testing is required. Yeah, so theme here, yes. So already thinking, so the FIB4, yes, we always start with, and then already thinking about liver ultrasound, so thinking about other etiologies here. So we plug in her values for the FIB4, we get a 2.80. Yeah, so an elevated FIB4. And those with an elevated FIB4 above 2.67. So yes, she would warrant additional non-invasive testing. However, given the elevated FIB4 score here, this would, based on the decision tree algorithms, this could probably warrant direct referral to a specialist. Although, depending on referral time and referral availability, I think additional non-invasive testing or additional workup is reasonable in that meantime. And so kind of to highlight here again, this patient population with a FIB4 above 2.67, those that, there's about a 20%, 21% chance of being high risk with this elevated liver stiffness. And so this kind of corresponds to that advanced fibrosis, an F3 or an F4 on a scale of 0 to 4. And given this high prevalence, referral, at least initiating the referral process is a good idea. And kind of these key takeaways from the initial screening, FIB4 being a test that was, as we've highlighted, it's kind of the simple, inexpensive initial screening test. The nice thing is that it incorporates commonly utilized labs, CBC and CMP. FIB4 is particularly studied between 35 and 65. So if you have a patient that is above 65 or below 35, just keep this in mind and consider alternative initial screening tests. The ELF test is particularly useful in these populations. The FIB4 cutoff less than 1.3 denotes low risk. So this is a population that does not need additional testing. And then remember, those above 65, you can use less than 2. And if the FIB4 is above 2.67, then referral to specialist is probably the best option given the high prevalence of advanced fibrosis. The ELF is an alternative blood test for screening those with at-risk disease, and the cutoff for low risk in this with this test is 7.7. And then in those who have type 2 diabetes or more than 2 cardiometabolic risk factors, you can repeat the FIB4 every 1 to 2 years, maybe leaning towards annually. And then otherwise, in those who you've performed a FIB4 in, if they do not have diabetes or they have less than 2 cardiometabolic risk factors, then repeating every 2 to 3 years is appropriate.
Great. Thanks, Matt. So now we're going to go sort of beyond FIB4. And since many of you may practice in a place where kind of getting access to that specialist may be more challenging, I think having another layer of testing to help risk stratify your patients is important. So of the sort of next level testing, there are 3 that are recommended. One of them I've already spoken to you about. It's the enhanced liver fibrosis blood test. So it can be used both for screening in some individuals, but it's also considered as a second level test, meaning if you have somebody with FIB4 and they're not less than 1.3, they're above that, you could use ELF as your next level testing to see if they fall into the higher risk category. but probably the one that's used most commonly is vibration-controlled transient elastography, and the most common version of that available is something called a FibroScan. But increasingly, I'm seeing this actually available through kind of your routine place where you get your ultrasound. Increasingly, they're also offering vibration-controlled transient elastography. So that's probably going to be the test you're going to get most familiar with. I also list MR elastography because that certainly has been studied, and in specialized centers that is probably used much more than than you might use, but it is one that's considered a second level testing. And then I just wanted to highlight 3 others that you might hear about, but are not currently recommended as second level testing. They're more typically used as first level testing instead of FIB-4. One of them is called the NAFLD fibrosis score. This is also one where you plug in age and ALT and various risk factors into a score, and then it spits out a number that tells you whether they're high or low risk. It's shown to be not perform as well as FIB-4, so it's one which I don't emphasize, but you may hear about it. The Fibro test is a commercially available test, also generates a number that says this patient has F0, F2, F3, and has reasonable performance characteristics, but again is a send out test, and FIB-4 performs just as well, so that's why I don't recommend it. And then you probably in the future, I think we'll hear more about what they call the FAST, which is combining FibroScan, which is this elastography, and AST into a score that has been shown to be highly predictive and better performing than FIB-4 alone. So this may become a test that we use as second order testing in the future, but this again is more limited availability. So I'm going to focus my remarks on VCTE. Next. So just to help you sort of get familiar with the numbers, this is taken from one of the most recent guidelines. So remember, I'm not recommending MRE, but there are values for MRE should you have this available. I don't recommend this really as the next level testing due to its cost. And I reserve MRE for those individuals in which I've done more than one test and I've got discordant results. What I want you to focus on is ELF and VCTE and how these are used to ascertain if somebody is low, intermediate, or high risk. So what you can see, we've already talked about ELF. So under 7.7, that's low risk. And so that is a full stop. You don't have to do more for that patient. But if their values are higher, so 7.7 to 9.8 is considered intermediate. That's somebody that probably needs more testing. But note that if their ELF test is over 9.8, that's a high risk group, and that's a person who likely has advanced disease. And if it's over 11.3, that person probably has cirrhosis. So it can be helpful in kind of delineating just how advanced their liver disease is based on the number. And then VCTE, which is elastography, the numbers here, and you'll have these slides, you don't have to memorize this, but under 8 is considered a level that's low risk. So often we'll do a FIB-4 first, and if their FIB-4 is over 1.3, we do VCTE. If the VCTE says it's 7 or 6, then we know they're in the low risk category. We're done in terms of testing. But note that again, if they have an intermediate, which is 8.1 to 12, or most importantly, if they're over 12, very likely they have advanced fibrosis. And it's recommended in general that those in the intermediate or high risk groups should be referred to a specialist, mostly for additional testing, but importantly also that those that are in the high risk group very likely have advanced fibrosis and need very specific treatment and monitoring. Next. So a little bit about the FibroScan. Next slide, please. Thanks. So this is what if you haven't seen it, this is what it looks like. On the left, you see the probe that's placed in a specific interspace in which they get an adequate ability to get a shear wave through the liver. And it's measuring liver stiffness in kilopascals. The individuals do 10 valid readings, and the readings are such that it's kind of you're doing an ultrasound at the same time, so you have to make sure there's no ribs in the way and that you've got good view, and then it's going to generate the liver stiffness measurements. Simultaneously, it measures controlled attenuation. And the controlled attenuation is the actual estimate of the severity of the fibrosis. So you get both liver stiffness and CAP, which stands for controlled attenuation parameters, on every VCTE. And that can tell you both whether the patient has fat in their liver and how much, but more importantly, here we're most interested in what's that level of fibrosis. Note that if you see FibroScan reports, you have to make sure that they are of good quality. They should have 10 valid measures that they've used to generate the estimates, and that the interquartile range across these measurements should be less than 30% for it to be valid. And shown on the right is just an example what the FibroScan actually looks like. And you can see in this particular case, the FibroScan value is 3.9, which is a very low value. This person does not have at-risk fibrosis. In fact, this is a normal value for liver stiffness. And you can see the IQR, which is shown on the bottom, is 0.7. So it's a very nice estimate in the sense that the IQR is really well within the range. In terms of preparing for this test, patients have to fast for 4 hours before procedures. If they've had a recent meal, it can affect the liver stiffness. And you have to make sure you use the right size probe. And if you have individuals who are obese, they need to use the XL probe for it to be accurate. Next. And VCT is an amazing tool, but I wanted to highlight that it's not a perfect study. And what I've come to recognize in recent months is that as VCTE is being more widely adopted, is that you can see that individuals who don't have experience in doing VCTE can yield really very inaccurate results. So I've already highlighted for you things like the patient has to be fasting for 3 hours. But the other thing to be aware of is if you have a patient, for example, whose ALT level is over 100, that can lead to an overestimation of liver stiffness. And it's generally recommended that you not use VCTE when the ALTs are very high. And the reason is that you're not then measuring fibrosis or stiffness due to fibrosis alone. You're getting a lot of inflammatory activity, and that can elevate the liver stiffness and give you a higher estimate of fibrosis than actually exists. The other thing is to be aware is that data has shown that individuals who are doing VCTE have to do at least 100 exams before they're really reliable. And so I have, just as an example, I get patients referred to me who've had a VTCE done locally, and the value came back as their liver stiffness being like 30, which would suggest they have cirrhosis and portal hypertension. And when I look at the scan, I can see that it's a poor quality scan. We repeat it, the liver stiffness is 7. So it really matters. You have to have people that know what they're doing. So just to be aware, when you're sending people for VCTE, best if you're sending it to a place that does them all the time, regularly, by technicians who are really skilled. Other things to be aware of is that other things can influence liver stiffness. If somebody's in right heart failure, that will raise the liver stiffness. If they've had a big drinking episode and have alcohol-associated hepatitis, that will raise the liver stiffness. All of this is not related to MASLD, but can cause those VCTE liver stiffness measurements to be elevated. So just be aware. It's a very good tool, but you want to use it in individuals who are appropriately prepared, they're fasting, that they have liver tests that are not so extreme that they could influence the results. They have to be sure they don't have concurrent conditions that could influence the liver stiffness, and you need an experienced operator. Next. So how do you kind of put this all together? And here is kind of my sort of big slide where hopefully it all comes in terms of first and second line testing. So let's start at the top where you have your individual that you realize should be screened for MASLD. So you're going to do your FIB-4 test. And Matt, can you just kind of circle things as I go through it? That'd be great. So you start at the top with your FIB-4. If your FIB-4 is 1.3 or greater, then that's a patient who needs second level testing. So we're going to go to the right of that diagram. Remember that if their FIB-4 is greater than 2.67, that's a patient in which in general it's recommended you should do the referral. Of course, you can do second level testing, but generally that's a number that's high enough that referral to a gastroenterologist, a hepatologist for further testing is in the realm of what's recommended. Those that have persistently elevated AST and ALT are also a group which generally are recommended for referral, in part to make sure that they're fully evaluated for other causes of AST and ALT elevation. And then finally, for those that have a FIB4 over 1.3 and you've done that second level testing, whether it's VCTE or ELF, here's how you can sort of use that information. Again, if you do second level testing, you do an ELF, it's under 7.7, they're a low risk patient, they go to the left. If you do a VCTE and it's 8 or less, they go to the left. No need to refer that patient for further evaluation by a specialist. But if they have intermediate or high levels, that's the patients that should be referred or have further testing done to establish stage. All right. So first level, FIB4, second level, VCTE or ELF. And if you have a low risk patient, that low risk patient stays in the monitoring. You work on, treatment's going to be covered in another session. But of course, in every patient, we're working on optimizing their cardiometabolic risk profiles to reverse their MASLD. But the group that's in that low risk is the group that works on lifestyle specifically and doesn't get referred to the specialist for drug-specific therapy for their MASLD MASH. Next. Now, just a word about liver biopsy. So I will honestly say I still do biopsies occasionally for patients with MASLD, but it's extremely rare, and most patients do not require it because our non-invasive tests, our NITs, are actually usually enough to establish the stage of fibrosis. So I don't need to do a liver biopsy. But when do we consider it? Well, there's really 3 instances. One is that you have done your non-invasive test and they're giving you discordant results. One says they're low risk, the other one says they're high risk. Well, you maybe do a third and it says they're intermediate. I definitely have that patient. Those patients, oftentimes liver biopsies, really the only way we can be certain. And the second sort of major reason is when we really suspect another disease, and probably the most common would be like autoimmune disease, where really we can't make that diagnosis without having a biopsy to help us. So when we suspect a second liver disease, and that certainly can happen because MASLD is so common, they could just be unlucky and have 2, then we would do a liver biopsy. And then the third that you may hear about is that many of the clinical trials, which are focused on MASLD and MASH, actually currently are requiring liver biopsy for entry because they actually use biopsies to judge the efficacy of the drugs. And so patients sometimes require biopsies for that reason. Next. All right, handing it over to Matt to highlight these points.
All right, and the focus here will kind of be talking about the risk stratification from this screening test. So this is a 56-year-old male patient, hypertension, prediabetes, BMI of 38. AST and ALT are 42 and 40 respectively. Platelets are 192. We have an ultrasound that shows mild steatosis. Look for risk factors with no alcohol or medications that are linked to steatosis and calculate a FIB4 1.9. So knowing this FIB4 1.9, is there any additional testing that's needed to determine the risk group? And then if so, which testing would you recommend? Yes, good. So highlighting that this kind of fits in the group that would need, the risk group that would need additional testing. Since it's above 1.3, but not quite 2.6 for the FIB4, we obtain an ELF and FibroScan or VCTE for this participant, for this patient. The ELF is 7.9. The VCTE gives us a liver stiffness of 8.1 kilopascals, which, what do we recommend based on these findings? Kind of here, so this is a patient that would fit just into that intermediate group. So we have here the ELF score of 7.9, VCT of 8.1. So these, technically speaking, just fit into that intermediate category. Just the key of that case was just knowing the cutoff of 8 and 7.7. Because these are in the intermediate group, it's reasonable to refer this patient to GI or hepatology care. Second case here, we have a 62-year-old female, routine follow-up, type 2 diabetes, BMI is 24, ultrasound shows steatosis. We have a FIB4 of 1.26. So this is, we can think about which group this fits in, but she does tell you that her brother was recently diagnosed with MASH-related cirrhosis. She's very concerned regarding her risk for cirrhosis. And so what additional testing or what testing would you recommend? We already have the FIB4 here, but is there anything else we would do?
Matt, maybe in the interest of time, we can just share the responses. Yeah, thanks.
Yeah, perfect. Yeah, so the, a good point here is kind of we can use we know that her FIB4 is near the cutoff for low risk, right? It's below 1.3, but fairly close. She has a positive family history. You move down to the second stage testing. The ELF and the VCTE are both less than the cutoffs and are both low risk. So we have here, VCT less than 8 for the liver stiffness and ELF is less than 7.7. So based on this low risk, we would feel comfortable repeating testing in 1 to 2 years.
I'll just point out that that patient, you could argue, well, I would have just reassured her that she's got a very low FIB4, right? But if you wanted to give a little bit more reassurance to that patient, that's where you could do this second level testing with relatively low cost and just really secure the diagnosis of a low risk MASLD for her.
And then we have a third case here, a 32-year-old female. She has had hepatomegaly noted, steatosis on abdominal ultrasound that was initially obtained for abdominal pain. Her BMI is 30, no diabetes, no hypertension, no known dyslipidemia. She does have a diagnosis of polycystic ovarian syndrome and takes oral contraceptives. She has an AST of 96, an ALT of 105, platelets are 240. You calculate a FIB4 that's 1.4. You're thinking, is there additional testing that's needed to determine the risk group? And if so, is there testing that you would recommend? So kind of one of the key points here is that this is a patient that has a very high AST and ALT. Remember, both are about 100. So this means that VCTE is not going to be a reliable test for second level testing. Her FIB4 was borderline, or was kind of in that intermediate risk group, so would probably warrant secondary risk assessment. But given the elevated ALT and AST, this is a patient that probably should be referred to GI and hepatology for further workup. And then just one other point to highlight from this is the kind of the coexistence of these other metabolic or endocrine type etiologies. Polycystic PCOS is something that's associated with insulin resistance, and so these are some comorbidities that you may see in patients who have risk factors or may have MASLD and MASH. And just the key takeaways from this, right? That FIB4 is recommended as the initial test for risk stratification. The ELF test can be used for additional second level screening to determine if at risk and needing referral. We use a FIB4 1.3 or 2.0 if above 65 years to kind of move down that path to second testing with ELF or VCTE. And then those who should be referred to GI and hepatology if they have an elevated FIB4 on that first test, if they have MASLD and elevated liver tests, particularly if above 2 times the upper limit of normal. So if you diagnose them or find them with MASLD and they have these persistently elevated liver tests, and then those who have the non-invasive testing that's in the intermediate or high risk range, or particularly those who have discordant results between several non-invasive tests, those should be referred for specialist care as well. And I want to thank you all for listening and, pause and see if we have any questions or anyone wanted to follow up on anything.
I see that we're at the hour, so I don't know if there's enough time for questions, but if people have questions, we're here to address those. And Cindy, if there's they want to come in after, we're happy to respond later too.
Oh, wonderful. Yes. If anybody has any questions, feel free to place them in the chat or call out and we can connect you after as well. I know we're after time, but I wanted to say thank you both so much. That was incredible. I know everyone, I've already gotten email feedback about how great you two have been. So thank you so much. I will also pop up our next session just so everybody can see the final 3 that we have right now. So these are the next sessions that we have coming up. And does anybody have any questions?
There was a question in the chat about the cost difference between ELF and VCT. Dr. Terrault, I don't know if you have a better sense about.
I don't know the answer to that. It's a great question. And it's partly because I think that it's the VCTE, I think is I'm not aware of how they charge for that. If they're doing it as part of an ultrasound, I think it's less than if they're doing they have their own machine and they're doing it. So I'm a little less certain about the cost of VCTE when it's done across centers. So I'm not sure. I think the real issue is access, to be honest. So I think you're going to have to find out, what do I have access to? And then use that as being the primary thing that's going to help you to do that second level testing. I realize that, if you're in rural areas, it can be very difficult to find somebody who has VCTE. And that's why I spent some time emphasizing ELF, because at least that is a send out test that you can get.
Thank you so much. I don't see any other that have popped up in the chat, but if we get more, we'll follow up after. But thank you both again. This was wonderful. Thank you all for attending and participating in the chat.